Imagine paying thousands of dollars for this highly specialized cosmetic procedure, right?
Right.
And it's designed entirely to enhance physical pleasure. But then you discover that the fundamental laws of physics basically dictate the procedure is going to achieve the exact opposite result.
It's incredibly counterintuitive.
Exactly. I mean, you undergo the treatment, you expect a specific mechanical outcome, but because of this, unseen structural deficit in your body,
Yeah.
the intervention just completely collapses under its own weight.
Yeah, the literal physical weight.
Right. And that is the reality for countless women who are seeking this popular cosmetic enhancement known as the G-shot. So welcome to today's deep dive.
Thanks for having me.
We have a really fascinating exploration ahead of us today for you. It sits squarely at this wild intersection of human anatomy, cosmetic trends, and hardcore biomechanics.
Yeah, and we are pulling from a really specific stack of sources today to get into this. We're looking at clinical guidelines published by the American College of Obstetricians and Gynecologists, or ACOG.
The gold standard, basically.
Right, exactly. We're also integrating these advanced biomechanical research papers focused on pelvic organ prolapse, and then cross-referencing all of that with literature from cosmetic gynecology clinics detailing their actual procedural protocols.
Which gives us the full picture. And the mission for this deep dive is to unpack a highly specific, kind of eye-opening question.
Yeah, a very specific engineering problem inside the body.
Exactly. How does pelvic floor muscle weakness, which is clinically known as hypotonia, actually affect the mechanical counterpressure required to make G-spot filler treatments work?
It's basically an architecture question.
Right. But before we get into the literal physics of the pelvis, I do need to clearly state that the sources we're looking at contain highly debated and honestly sometimes totally conflicting viewpoints regarding cosmetic vaginal procedures.
Oh, absolutely. The medical community is very split on some of this.
Yeah, so our goal today is not to endorse any specific viewpoint or condemn any procedure. We are simply here to impartially unpack the fascinating science and the biomechanical ideas contained in the original source material.
So you can understand the physical forces at play.
Exactly. So where do we start?
Well, before we can understand how muscle weakness affects the procedure, we first need to define the physical space and the procedure itself.
Okay, lay it out for us.
So the concept of the G-spot is inherently pretty controversial in the medical literature.
Like anatomically speaking.
Right. If you look at the work of researchers like Dr. Vincenzo Pupo, the argument is that it doesn't anatomically exist as a distinct organ.
Wait, really? Not an organ at all?
No, not according to that view. He asserts that from a histological standpoint, you just can't dissect the tissue and isolate a singular gland, not in the way you would, like, a kidney or a thyroid.
Okay, but obviously the cosmetic industry is targeting something.
Right, and that's where other researchers and cosmetic clinics come in. They describe it more as the CUV complex, which stands for the clitoretrovaginal complex.
Clitoretrovaginal. That is a mouthful.
It really is. Basically, it's a convergence zone. It's located on the anterior or front vaginal wall, maybe 5 to 8 centimeters inside.
So it's not one organ, it's basically a highly sensitive intersection.
Exactly. It's where erectile tissue, the urethra, the internal structure of the clitoris, and Skene's glands all overlap. So it's this incredibly dense region of concentrated sensory input.
Okay, so that localized density of nerve endings is what the cosmetic clinics are targeting with G-spot amplification.
Right. Commonly marketed as the G-shot. The procedural literature outlines this non-surgical intervention where they inject dermal fillers directly into the submucosal space of that anterior wall.
And when we say fillers, we mean
mostly cross-linked hyaluronic acid.
Like the exact same stuff people use for facial contouring or lip filler.
Basically, yeah. Or sometimes human-engineered collagen.
Yeah.
But the mechanical objective here is purely volumetric.
Meaning they just want to make it bigger.
Right. The clinics are trying to temporarily plump this CUV complex to about the width of a quarter.
Wow, okay.
Yeah, and it creates a localized projection of about a quarter inch into the vaginal canal.
A quarter inch doesn't sound like a lot, but internally I guess that's significant.
It's very significant. And the clinics claim that creating this projection increases the surface area for direct friction during intercourse.
And friction equals sensation.
Exactly. That increased friction theoretically translates to enhanced sexual arousal and stronger orgasms for, the 6 to 8 months before the body naturally metabolizes the filler.
Okay, so mechanically speaking, if sexual pleasure relies on friction, The G-shot is essentially like putting a physical speed bump on a road to ensure the tires actually make contact with it.
That is exactly the logic. You're building a speed bump to guarantee the tires hit it. But ACOG approaches this volumetric theory with extreme caution.
Because it's not a medically necessary speed bump.
Right. Their committee opinion explicitly states these procedures are not medically indicated. They point to a serious lack of robust, peer-reviewed clinical trials documenting safety and efficacy.
And I imagine there are risks involved with just, injecting filler into such a sensitive area.
Oh, definitely. They outline specific procedural risks like altered sensation, scarring, adhesions, and dyspareunia, which is painful intercourse.
So it could actually cause the exact opposite of pleasure.
It really could.
Okay, so that speed bump analogy perfectly sets up our next point. If the filler is the speed bump, what happens if the road itself is, well, sinking?
Right. You can't build on a bad foundation.
Exactly. To understand that, we need to look at the biomechanics of the pelvic floor, right?
We do. And the structural integrity of the pelvis is honestly just a marvel of biological engineering.
Walk us through it. What are we actually looking at?
So the pelvic floor is a hammock made up of 14 distinct muscles.
14. Just in that one hammock.
Yep, 14 muscles arranged in 3 interlocking layers. But it's far from just being a passive sling.
Right.
It's constantly engaged in dynamic load management. Researchers use this thing called vaginal manometry to measure internal pressure gradients.
Like literally measuring the squeezing force inside.
Exactly, and they've identified a distinct vaginal high-pressure zone located right in the mid-vagina.
Wait, so the pressure isn't the same everywhere?
No, it's distinctly asymmetrical. It registers much higher on the anterior and posterior walls than on the lateral or side walls.
Oh, wow. So the body is naturally generating an asymmetrical pressure clamp right where that CUV complex sits.
Yes, it is creating its own inherent friction zone. And it maintains that pressure zone through a highly specific architectural alignment. The sources call it the dome effect.
The dome effect.
Sounds structural.
It relies on precise angles. The posterior fornix acts as a mechanical fulcrum. And because of this, a healthy vagina naturally maintains a 90-degree functional folding angle with the levator plate.
And the levator plate is what, like the main shelf of muscle?
Yeah, it's the primary supportive muscular shelf of the pelvic floor.
Wait, okay, I have to push back on this a little bit.
Sure, go ahead. If the pelvic floor is angled at 90 degrees to catch downward force, how does that hold up under extreme dynamic shifts? I mean, if someone is doing a heavy deadlift at the gym, or even just coughing violently, the intra-abdominal pressure spikes massively, right?
Oh, yeah, it skyrockets.
Wouldn't that sheer downward force just push the entire 90-degree system forward and totally out of alignment? How does the levator plate actually keep it anchored?
That is where the load-bearing mechanics are just so brilliant. The levator plate doesn't just passively resist the force, it actively redirects it.
Redirects it where?
Towards the bone. When you cough or lift something heavy, that 90-degree angle ensures the downward kinetic energy is caught and distributed posteriorly toward the sacrococcygeal axis.
Okay, so the tailbone area.
Right. The force is routed into the hard bone structure rather than pushing straight down through the muscular opening or hiatus.
That makes so much sense.
Yeah, and with vaginal tactile imaging, researchers can actually map these pressure gradients in real time. In a healthy pelvic floor, when the muscles contract, they generate significant localized counterforce.
So they instantly stabilize the organ.
Exactly. It maintains that mid-vaginal high-pressure zone despite whatever heavy abdominal load is pushing down.
This completely recontextualizes the anatomy for me. The pelvic floor isn't just a passive hammock sitting there holding organs like a bucket. It's an active, dynamic structural system providing literal physical counterpressure.
It is entirely active.
So what happens to that carefully engineered 90-degree angle in that high-pressure zone when the musculature fails?
Well, this is where we introduce the pathology of hypotonia.
Which is what our whole mission today revolves around.
Right. Hypotonia basically refers to a pathological reduction in muscle tone, strength, and elasticity.
And what causes that?
Clinically, we see this structural degradation a lot following the trauma of vaginal childbirth.
Sure, that makes sense.
That also just through the systemic tissue changes of the natural aging process or via perineal body shortening.
What's perineal body shortening?
It's when the critical connective tissue that anchors the vagina and rectum gets damaged or tears. When any of these traumas alter the length-tension relationship of the muscles, the contractile efficiency of the system can just plummet.
Plummet by how much?
By like 40 to 60%.
Wow. A 60% loss in contractile force. I mean, that means the levator plate can no longer redirect those downward pressure spikes to the tailbone.
Exactly. The 90-degree functional folding angle just collapses. The structural failure is immediate.
This is the trapdoor basically falls open.
Yeah, the levator hiatus widens, and the system loses its ability to manage intra-abdominal pressure. And this is where the biomechanical literature uses an amazing concept called the sailboat effect.
The sailboat effect.
Yeah.
To describe what?
To describe the fluid dynamics of what happens next. Once the vaginal walls lose their muscular support and begin to descend into that widened gap, they enter an unbalanced pressure differential.
Right, because the pressure inside the abdominal cavity is always significantly higher than the atmospheric pressure outside the body.
Exactly. So that higher intra-abdominal pressure pushes down on the descended vaginal wall exactly the way wind catches the canvas sail of a sailboat.
Oh, wow. So it's literally catching the pressure like wind.
Yes. It generates a continuous driving force. And physics dictates that a larger sail catches more wind, right?
Creating more kinetic energy.
Right. So as the anterior wall descends further down, a larger surface area is exposed to this pressure differential. It creates this brutal positive feedback loop.
The more the tissue descends, the more pressure it catches, driving the prolapse further and further downward.
Precisely.
Okay, let's bring the pieces together and apply that localized fluid dynamic to the cosmetic procedure.
Let's do it.
So a patient is experiencing hypotonia. Her levator plate is compromised, that crucial 90-degree angle has failed, and this wind in the sail pressure differential is constantly pushing on her anterior vaginal wall.
A very common scenario, unfortunately.
And then, seeking enhanced sensation, she opts for a G-shot. A clinic injects a dense, quarter-sized mound of cross-linked hyaluronic acid directly into that descending anterior tissue.
Right.
Based on the mechanical vectors we just established, the procedure is doomed before the filler even settles.
The biomechanics simply do not support the intended outcome. I mean, the procedure's goal is to create friction by adding volume. But because the underlying hypotonia has completely destroyed that vaginal high-pressure zone, there is no mechanical counterpressure.
The hammock isn't pushing back.
It's just not.
So if you get this filler, but your pelvic floor is weak, does the extra volume just cause the anterior wall to stretch or balloon outward instead of creating that pleasurable friction?
That is exactly what the source material notes. It says amplification to the anterior wall can just cause ballooning if the underlying support isn't functioning.
Because you're injecting a dense bolus of filler into tissue that is already yielding to a pressure vacuum. The added mass just exacerbates the sailboat effect.
Exactly. Without a firm muscular backing to compress against, the filler just doesn't project upward to create friction. The tire just pushes the speed bump deeper into the mud.
You have successfully added volume to the tissue, but you have fundamentally failed to create the friction or the sensory feedback that you are paying thousands of dollars for.
You're attempting to solve a deep structural deficit with a superficial volumetric addition. It completely ignores the load-bearing reality of the anatomy.
Right. Adding mass to a hypotonic system only increases the gravitational burden.
Yeah, on a tissue structure that is already failing to manage basic everyday abdominal pressure.
So the physics clearly dictate that you cannot engineer friction without counterpressure.
No, you can't.
Which brings us to the obvious question. If injecting filler into a sinking anterior wall isn't a standalone magic bullet, how do you actually restore that vital counterpressure to improve sensation?
Well, the clinical literature suggests shifting the focus from localized volumetric augmentation to holistic neuromuscular rehabilitation.
Okay, meaning what?
Meaning you fix the muscle. The research highlights this vital physiological feedback loop, often referred to as the pelvic floorgasm.
The pelvic floorgasm.
Yes. Female sexual response is actually deeply intertwined with pelvic floor contractility. During orgasm, these muscles undergo rapid reflex contractions, closing forcefully around the vaginal opening.
Oh, so stronger muscles literally equal a stronger orgasm.
The data indicates a direct correlation, yes. Greater capacity for arousal and more intense, prolonged reflex contractions.
So building the structural foundation naturally restores that localized pressure clamp around the CUV complex.
Precisely. And the foundational intervention for this is targeted Kegel exercises. But the literature really emphasizes that technique is paramount here.
Right, because most people probably do them wrong.
Oh, completely. It is not about simply bearing down or clenching indiscriminately. That can actually increase intra-abdominal pressure and make a prolapse worse.
So how are you supposed to do it?
The clinical visualization the sources use is attempting to pick up a blueberry with your vaginal muscles.
Wait, pick up a blueberry.
Yeah. It's a highly coordinated upward lifting motion. You're trying to engage the specific layers of the pelvic floor without engaging your abdominal muscles.
Okay, visualizing picking up a tiny blueberry definitely changes the mechanics of how you squeeze. That's a great cue.
It really is. But for patients where hypotonia has progressed significantly, where the weakness is severe, neuromuscular reeducation is incredibly difficult.
Because gravity is constantly fighting them.
Exactly. Gravity is driving blood pooling and tissue descent into that widened hiatus constantly. So in these severe cases, the clinical literature introduces the integration of targeted external compression garments.
How does an external garment actually alter the internal forces we were just discussing? Like, how does it stop the sailboat effect?
Well, garments designed for pelvic floor support, they function as an engineered external hammock. By providing targeted upward counter pressure against the perineum, they literally externally interrupt that pressure differential.
It sounds like trying to flex a bicep that's completely exhausted from carrying heavy groceries all day. The external garment acts like a spotter at the gym.
That is exactly what it does.
It supports the weight, giving the exhausted pelvic floor muscles a break so they can actually rest and remember how to contract effectively.
Right. It externally stops the wind from catching the sail, and that gives the muscles the mechanical grace period they need to return to their optimal length-tension relationship.
And once that resting tone is restored, then they can actually benefit from doing the blueberry kegels.
Exactly. You manage the load externally, you allow the internal architecture to heal and re-engage, and once the levator plate regains its contractile efficiency, that critical 90-degree angle is restored.
The tailbone can manage the pressure spikes again, and the natural high-pressure zone returns.
And with the return of that natural clamp, the physical friction and sensory feedback localized around the CV complex is restored, completely without the need for synthetic volume.
It is just incredible how deeply interconnected the human mechanical system is. I mean, we really went on a journey today.
We covered a lot of ground, yeah.
We started by looking at the totally controversial anatomy of the CUV complex and moved into the cosmetic application of hyaluronic acid fillers.
Then we mapped to the complex physics, the dome effect, the dynamic load-bearing capabilities of the levator plate.
Right, and we analyzed how hypotonia triggers that sailboat effect, creating a pressure differential that makes adding cosmetic filler virtually useless. I mean, you can't just add filler to a system that lacks structural counterpressure.
No. Adding volume without counterpressure just causes the tissue to balloon downward. You cannot treat a collapsing foundation by just, patching the drywall.
You have to restore the foundation. Whether you are exploring cosmetic enhancements or just trying to understand your own anatomy, you always have to look at the underlying structure.
Absolutely.
Which leaves a pretty profound question for you, the listener, to consider on your own. We spent this entire deep dive analyzing how vital the pelvic floor's tension and active counterpressure are for physical sensation, sexual pleasure, and just overall organ support.
Right.
Given that absolute biomechanical requirement, how might the modern trend of chronic sitting and highly sedentary lifestyles, which we know systematically shorten the hip flexors, weaken our core, and atrophy the pelvic musculature, be quietly reshaping the human sexual experience on a population level?
That is a terrifying thought, honestly.
Are we inadvertently engineering our own structural hypotonia just by sitting around all day?
Yeah.
It's definitely something to mull over the next time you find yourself stuck at a desk for 8 uninterrupted hours. Thank you so much for joining us on this deep dive.
It was a pleasure. Thanks.
We'll catch you on the next one.